Turner, and I'm an occupational therapist, and you'll meet Robin in a second. She's just standing beside me. We're going to talk about some of our complex kids and how we can include neurodevelopment in this population. We have no conflicts of interest to disclose.
Just to swing back a little bit. Yeah.
Thank you. Hi. And our objectives today is to really recognize the impacts of this critical illness on neurodevelopment, to gain an understanding in basic neurodevelopmentally supportive care, which can be implemented in the hospital at different levels of care, whether it's the ICU, inpatient settings, and to identify the potential impact of acquired brain injury in this at-risk population. First, we'll do a very brief literature review of neurodevelopment in the congenital heart defect population. We're going to define what neurodevelopmentally supportive care is. We have a couple videos to review typical and atypical neurodevelopment. We're going to discuss the factors that impact neurodevelopment with these kids, and then talk about some of the strategies that can be employed in the acute care setting to help them. So first off, we just want to review what is neurodevelopment. It's a term we hear very often, and this is a very formal definition, but I think of it as the process that the brain is taking to mature over the course of the lifetime. So the pathways that it's making and the function that it's developing from the moment of conception all the way until we pass away. And we assess, or we can observe, neurodevelopment is happening through behaviors, through our social skills, through our cognitive skills, through our movement. And so that's why we end up talking a lot about different milestones and different skills that we have or don't have in certain diagnoses. So what do we know? We know that the congenital heart disease population has about 9 in 1,000 live births. And this number has kind of settled out over the last 10 to 15 years. And long-term survival has improved in this population. Depends on the diagnosis, but overall there's improved survival. But what we wanted to highlight in this lecture is that survival is not the measure of success anymore. The quality of life that occurs after these children have surgery and are repaired and through their whole journey is really what we need to start thinking about. And it has been thought about for the past 15 to 20 years, but we have a lot more information to share with you about how to support these kids. We know that babies are at increased risk of brain injury, and we'll talk about some of the factors affecting that, and that brain injury and just being a part of the hospital environment at such a young age can lead to increased risk for poor neurodevelopmental outcomes. So what factors are impacting brain injury and neurodevelopment? We know from the get-go, these kids don't come to us at birth with the same brains that other kids have. They have delayed or even abnormal brain maturation. And there is also evidence to show that there's in utero brain injury. And more recently, there's other factors that looking at beyond sort of the antenatal and perinatal factors. There's also things looking at SES that is helping us understand the full picture. I have a little box there pulled from one of our articles, and it's not really meant to go through line by line to help you learn all of these specific factors. It's really there to help highlight how many factors these kids have that are impacting them. I'm going to pass it over to Robin now.
Hello there. So I'm Robin, and I'm one of the physiotherapists here at the hospital. So the question then comes, how do we support neurodevelopment for the children who are in the hospital? And developmentally supportive care is a philosophy and framework to optimize neurodevelopment in the hospital. And it has been proposed to be used to support our little babies with congenital heart disease. It is important, however, to note that it's really important for any of our children that are in hospital, although it has been recognized that the younger children, those who have not yet achieved motor milestones, those that have cognitive, especially their social, cognitive and motor milestones, or those who have a prolonged ICU or hospitalization are most at risk. And so a lot of our attention goes to this group of children. And we could have reviewed with you typical development, but we actually, in terms of talking about milestones, when do children usually learn to sit or crawl or roll? But what we thought we'd do is show you a video highlighting some of the really nice aspects about development that really include all areas that we would be looking at. And I'm hoping that this video actually works. I'm hoping that you can see it. Please let us know. This is a little 4-month-old young man, and he really highlights, I think, well, a lot of the key things we are looking at when we're talking about typical development. We see that he is moving constantly in the video. As he is 4 months old, he's able to hold his head up. His head is nice and erect. But also importantly is he's very calm as he explores these movements. His little body never really stops moving at all. And there he is sort of socially engaged with his caregiver. He's looking at the toys, he's reaching for the toys. But even though his gaze might be, engaged, he is calm and reactive and receptive to everything that his mother is showing him. And there he goes, we see something, we want something, we are figuring out how to move our body around to get it. When we stand him up, he has some nice tone in those legs. They're starting to push out against the ground. And, he's still interested in the things. And here we're challenging him with a position where he's clearly not yet ready to sit on his own. He's pretty calm about it. He reacts appropriately when he starts to lose his balance. He falls into a new position, and he still maintains this nice, calm demeanor. And when we look at the factors that impact, this child's development from a movement perspective, from a social perspective, from a cognitive perspective, we think about factors being sort of divided into two sort of categories. There are intrinsic or child-focused characteristics. These are the things that we may or may not be able to have impact on. So we think of things like underlying tone, whether they've had a surgery and they're healing from that surgery. But there are also extrinsic factors related to tasks or things that they are exposed to, experience, and environment that we can impact to hopefully optimize or support the development of these children. What we have now and what we're seeing both in hospital and in the community is an increasing number of children who are medically fragile. They are more complex, they have multi-system impairments sometimes, they are technologically dependent, and their hospitalizations often are longer and often more frequent. And these children often undergo invasive medical interventions such as surgery. They might be chronically ventilated. They might have due to the complex nature of their surgeries, they might have had a delayed chest closure. They might have had a period of ECMO. All of these things are going to be risk factors for developmental outcomes. And when we think about also the technology, we know that impacts their movement. It limits their movement because it may actually be weighting them down in some way, and it certainly impacts the parents' ability to connect with them when they're just as worried about the lines and tubes as they are about bonding with their child. And so this video represents more what we typically see in the hospital. And this little one is 8 months old and has been in hospital. Oh, I think I flipped to the next slide. Let me there we go. So she's 8 months old, and I want you to think back to the video you just saw of the 4-month-old little guy, his continuous movement. She's pretty calm. She's even happy at moments. But look at her amount of movement compared to the little guy we just saw. She does have some lines. She has an NG, she has a PIC line, which is coming out of her sleeper at the bottom. She can manage to reach against gravity, but for the most part, her limbs, lay against the support surface with much, much less general continual movement. And movement appears much more ballistic for her. She's moving and then she rests, and then she moves and she rests. And it seems like it takes a lot more out of her. And there's just really a much more, I kind of phrase it as being a bit more passive with what's going on around her. I'm going to fast forward the video a little bit just to show her in different positions. You can see we put her on her side. Her head isn't really lifting. She kind of uses the weight of her body to just fall back onto her back. Here she manages to get over to the other side by using some strength, but can't maintain it. When we put her in a challenging position, and just like we did with that other young man, she doesn't put her hands forward. She doesn't know what to do. And she starts to appear a little bit more distressed by this position because it is a lot of work. When we put her in standing, you can see she locks and then her legs just give out. It's a little bit trickier to see with her pants on. So we change her position a little bit there. And you can see she doesn't really push into the support surface at all. And when we, last but not least, try her on her tummy, this was saved for last purposely. This is immediately an upsetting position for her. She doesn't lift her head the way the 4-month-old did. She's quite upset, starts to look for ways to soothe herself. I start to look for something that she can use to soothe, and she's figured it out on her own by this point and uses her own hands. So the ability to deal with the environment, with challenging positions, is definitely very much affected in these children who are here for a long time. So some of those things that we saw might have been intrinsic. She might have a little bit of a lower tone. I think she clearly does. She may not have had the experience in the past to know how to deal with some of those challenging positions. But as healthcare professionals taking care of her, we are able to think about ways that we can modify her environment to maybe increase her exposure to these sorts of things so they don't become as so dysregulating for her. This is a picture of a typical room on 4D. And if I would love for those of you who can unmute your mic to kind of identify maybe some things we could do in this room to actually make it a little bit more supportive developmentally for this child. Does anybody have any ideas towards this? I don't know if the mics actually work. I'm not hearing anything.
Adding a mobile or like colored posters.
I think I can hear a little bit. I think I just need to do something with the volume. Can you say that again?
Yeah, adding a mobile to the crib, adding like colored posters just for stimulus.
Yeah, so I think Katiana's identified mobiles. Absolutely. Anything else?
Pictures regarding small cartoons or toys, like pictures can be displayed.
Yeah, instead of having the news on, maybe if you wanted to actually show her some screen time, you could change it to something more supportive. Anything else that stands out in this room? Don't worry, I'm going to give you some answers at the end. This is the room with a few simple modifications.
You can open the blinds.
Yes. Thank you. Opening the blinds. I think one of the things that we forget a lot of the times with our kids that are in hospital is that natural sunlight, or and is so important for helping to regulate day-night cycles. So having lights on during the day and the window open is a great idea. We can see someone mentioned, so I've heard this one, opening the blinds. absolutely having a mobile or something for appropriate visual stimulation and auditory stimulation. Our preference would be to actually limit the screen time so that the child can interact with their toys more so than the screen, but we recognize that sometimes, you know, we might need to put something supportive on it. So if you were gonna, or we might need to have the screen on, so it's putting something that's a little bit more supportive, like music or a nice video would be better than the news, I agree. This child looks big enough to be down on a mat and playing. Most children, when they are at home, will have some floor time or some flat play time on a mat of some sort. So ensuring that the child has that. Really important is a suitable seat. So we know that there are lots of options. There's bouncy chairs. These are this chair right here is called a tomato chair. We also have tumble forms on the ward that provide a lot of support for the children to be upright so they can see their environment and thereby better interact with it. Someone mentioned the lights. Absolutely. During daytime, the lights should be on. Blinds should be open as much as possible. And then all of the rooms have this little, a whiteboard. So encouraging families to create an all about me board or display or highlight things that their child likes or dislikes, what calms their child is all really important to help provide the best stimuli for them. The last one here, whoops, is that we have a program on 4D and in the ICU, it's evolving in the ICU called the Beanstalk program. And with part of that program, we actually have developmental cards or activity cards. So giving parents ideas for the activities that they could be doing with their child, not about what age they're at, but at about what developmental level they're at is really important. And if you don't know about this program, feel free to reach out to your allied health members on the wards. Thanks guys for participating. I think, is this me or is it you?
Well,
I think we switch right.
Yeah.
So we're going to talk about developmentally supportive care a little bit more in detail in acute care. I'm going to hand over to Kate.
Thanks, Robin. So we've talked a little bit about the environment on a cardiology unit, and we're going to get into a little bit about how the extrinsic environment can impact the baby. And I would argue it also impacts the parents because the hospital is a very stressful environment. You can tell from this picture in the ICU here at Sick Kids. There's a lot going on, and some of us may be familiar with this environment, but if you're new to the world as a baby, or if you're new to hospitals, like most of our families, this is incredibly stressful. And it leads to disrupt sleep routines. A lot of these kids have very painful, noxious stimuli happening, blood work, procedures. They're unwell, so they're restricted and they can't leave their bed. They may be bedbound. I know it's happening less, but there still is occasionally use of restraints. Having inconsistent people at the bedside in terms of caregivers. Obviously, parents are encouraged to be as much as possible, but having the number of people at the bedside that a child requires as part of their care in hospital is not typical of a home environment. You wouldn't necessarily be seeing quite the turnover. It's loud. The ICUs and the hospital in general has overhead announcements. There's technology that's loud. There's beeping. There's lights. I mean, a lot of these kids nursing requires good eyes on to see skin color and things. And that's stressful. Depending on the age of the child, there might be some separation anxiety. And also depending on what your setup of your hospital ICU or inpatient unit, there could be lack of privacy. And especially in some of our older kids, they may be observing some really adverse events in neighboring bed spots. And all of this is very stressful. I'm not sure why there's these little squares beside anyway, that's, sorry about that, we'll take it out. But the consequences of some of these stressful environments is what you see in the behavior of the child. So there can be poor state regulation, you can have motor delay from not being able to move, loss of range of motion, flattening on the head or plagiocephaly, difficulty with neck tightness or torticollis. You can have delayed acquisition of social skills because they're just not having that one-on-one time with a consistent caregiver in the same way. Sensory processing difficulties from having such an unusual environment at the beginning of life, and delayed oral motor skills and hypersensitivity in the mouth. So we're going to go into these in a little bit more detail. Both Robin and I are going to split these up. So first, we're going to talk about state regulation and self-regulation. And why have I given this slide a whole this topic a whole slide is because it is a base skill that we all need, not just babies and children, but also adults in order to learn and grow and develop. So if you imagine yourself getting a phone call in the middle of this conversation or talk right now and finding out some devastating news that just rocks you and you're unable to think straight, you're unable to keep your composure, you're crying, you're not going to be able to hear and understand any of the information I'm about to tell you. So state regulation of a calm, alert state is incredibly important. Children start with state regulation at birth, and you'll see these observable states of calm, alert state, sleeping state, crying state, and there's a few others, but I'll just keep it at that. And as they get older, a consistent caregiver will slowly learn to move these children into a co-regulated state. So you may be able to calm the child with assistance from a caregiver, and then eventually they'll be able to self-regulate. And I would even argue that as an adult, sometimes I need co-regulation depending on the situation. So I just wanted to leave that as like a very important base skill to be able to build any other developmental milestone. And you will see in babies that good regulation, and I mean in adults too, you can be shaking when you're not in a good regulated state. So you'll see smooth movements when you're well regulated. You'll be able to calm yourself or be easily calmed by someone else. You'll transition between sleep and alert states very smoothly and not slowly necessarily, but calmly. And you can maintain a calm alert state well. But if you're poorly regulated and stressed, I would argue, then you'll have frantic or jittery movements. You can't calm. You'll have sudden transitions between sleep and awake states. And even with support, you can't achieve a calm alert state. And this is also observable in autonomic changes. You can see increased heart rate, increased rest rate, hiccups, yawning. These are all sort of things that we observe in our babies. But if you're very attuned, you can see it also in adults. I'm sorry, I can't see there. So how do we tap into these children to decrease their stress and improve their state regulation? For babies specifically, it's important to provide the right sensory input that's developmentally appropriate in the right situation. And I think of a continuum of being hyper alert to calm, then being hypo alert and asleep. There's sort of a range of behavioral states or state regulation that kids have. And if you have a kid that's shutting down because they're overwhelmed, you need to gently increase stimulation to help them, or decrease stimulation to help them become more alert. If you have a kid that's hyper alert, you need to reduce stimulation in order to help them achieve a calm alert state. So I'm going to get into this in a little more detail in the next slide, which isn't changing. Sorry. There we go. This is a list of different things that you can do in most areas of a hospital. Calming alert music, calm voice, especially in the first 3 to 4 months of life. Those basic calming strategies of rocking, swaddling, white noise can be very helpful. making sure the appropriate light level is on. So if the kid is sleeping, if you're able to and it's safe to do so, decreasing the light. If they're awake, turning on the light. Using age-appropriate toys and books that are in the view of the child, but then at the same time not leaving those iPads if they are listening to music, or toys or mobiles if it's overstimulating the child, making sure to remove that stimulation. As the child is calm and alert, then you can build beyond that, and that's what Robin and I are going to talk about for the rest of this talk a little bit. Giving them toys that they can use their hands. So taking away the restraints and the mittens when it's safe to do so, and when they have a caregiver on site, that they can then use their hands and learn that their hands exist and aren't just pinned to their sides. Bringing things in view so they can learn that they can see their hands and see their hands to be able to use them. And then obviously for older kids, you can see the one on the left-hand side has a coloring marker and stuff that they're doing in their bed to, again, build those skills. I'm going to get into oral motor stimulation in more detail at 11 o'clock at the next presentation that I do. But oral stimulation can be calming for some kids. Non-nutritive sucking is one of the ways that babies learn to calm. And when we have these kids unable to bring their hands to their mouth, or they've had a lot of noxious stimuli to their mouth area, they don't learn that their mouth is a place that can be used for calming. And they also don't realize that it's a place where they can use their mouth to eat if they haven't had that experience. So making sure to, obviously there's going to be things that have to be done because of the hospital environment around their mouth, but also having positive things happening around their mouth and then following their cues. And again, we'll talk about that more in a bit. I'm going to hand it back over to Robin.
So the next thing after we think about having that calm alert state, starting to use our hands to do things, would be experiencing different positions and being able to be calm while also then trying these new positions. And one of the big things that we talk about with newborn babies and with developing babies is the importance of tummy time. It is important because it's important for the development of back and neck and chest strength, and our children have had sternotomies, so we have to be aware of that and do it at the right time. But we also have to know that because of those surgical interventions and because of their time where they could not experience tummy time, those muscles may be turned off or may be very weak, and that being in that position is going to feel a little bit more stressful for them. But it is important because it helps to prevent positional plagiocephaly, positional preferences, so children who might look to one side or the other as a preference, and avoiding having that plagiocephaly or flattened areas on their head. It is more challenging with ventilated patients due to the tubing and things like that. But the important thing I think to know is that you can try these positions, and it's okay once the sternum is healed to do alternate, we call it alternate positioning. So it can be over a roll, it can be on a caregiver's chest. So having technology shouldn't prevent us or prevent these children from experiencing these very important developmental positions in a way that allows them to be gently supported to progress in those areas. For supine, well, our children do get a lot of supine, particularly though if they're requiring a lot of support or in the immediate post-operative times. If the child is not really moving very well on their own, supportive positioning in supine can help prevent joints from becoming contracted, so we don't end up with froggy positions. And the goal of this kind of position would be to help avoid muscle tightness or changing the length tension relationships of the muscles to improve the child's ability to be able to come to the middle, which is actually very supportive for them to be organized and regulated. And so sometimes for children who aren't able to achieve these positions on their own yet, we might use some supportive roles to help provide that support for them when they're supine. The important things to think about would be supporting their shoulders to come together so they're not out here, which is a little bit disorganizing for many of us, but to give them little rolls potentially under their shoulders so that they can more easily find their hands for soothing. We don't want their hips to be out in the sort of froggy position. You can use rolls behind their hips again to help bring their hips more to the middle position. But at the same token, we don't want them too close together because it shouldn't restrict natural movement of their limbs. We want them to be able to experience movement, but sometimes when you're all the way out here, to even initiate movement is a big challenge. So by bringing them sort of towards the midline, we can help them to find that movement a little bit more naturally. So whatever positioning strategies we use, we still want them to actually move. And then one of the important things I think when we see our children in the beautiful nests in their crib is that once they are moving and they're ready to do more, to take those nests away so that they can explore wider movements, bigger movements, and not be so self-contained, because then it can become an actual inhibit. It could inhibit natural movement. I wanted to put this in just about swaddling in supine. We often know our children need a little bit of that pressure, that hug to help promote state regulation when they're here in the hospital. There's been a big push around looking at healthy hips, and we know that all infants are at risk of hip dysplasia. Hip dysplasia is a condition where the hips are more likely to be dislocated. It's an underdevelopment of the hip socket. And we know that for kids with congenital defects, that is actually an increased risk. So a note about swaddling, if you are going to swaddle to help the baby calm, is that we want to make sure that you swaddle them in a way so that their legs are still able to move. So you're not trying to bring their legs together. So you can, as the position on the right shows, the baby's nice and swaddled in their arms. So we're tucking the hands in, and we already said this helps with calming down. But their legs should still be free to move. So we're not really wrapping up their legs. It should be nice and easy for them to bend their legs up and down. They're not coming too close together. We can use side lying as a supportive position to help babies find their middle again. Also, it makes it easier for them to explore their hands, bring their hands potentially to their mouth to self-soothe, self-calm, self-regulate. It also reduces pressure on the back of the head. And we sometimes use side-lying position therapeutically to help undo or help treat some of the head flattening we might see. The important thing, I think, if we're going to do some supportive supine side-lying positioning, is to make sure if you're going to use a roll behind the back, it is good to help them stay in that position if that's a goal and they're calm there. But we want to make sure that there isn't a lot of pressure on the back of their neck so that so the roll doesn't actually put them into a flexed position, but allows them to still move their head, because respiratory wise, they may need a little bit more extension. And also the goal may be to not have pressure on the back of the head. Supportive positioning also includes being up against gravity. And I already mentioned we have a lot of options for seating depending on the size and the developmental status of the child. Upright positioning supports better breathing for our kids who are post-surgical. We cough we have a much better cough strength. Infants are diaphragmatic breathers, so this positions their diaphragm at a much better place. It will also help with their development of head and trunk control. And it gives them that engagement both visually, and if we support them in the right way, they can also use their hands in a way against gravity in the environment. Looking at the ceiling has got to be not too developmentally stimulating. There, as I said, variety of options, and I think one of the things we should be encouraging just as much as anything else is being up in parents' arms, because as Kate mentioned, being in the hospital is stressful. It would be important for both mom and babe to be, or dad and babe to be bonding. I also wanted to touch on some of the older children although this is about development, and we said development goes until age 18. So I want to touch a little bit again on that technology piece. What we know is that sometimes we have children who are technology dependent, who are actually, maybe it's a sudden illness, or maybe they have developed and they are alert and cognitively intact, and they want to be engaged in the community, or they have the ability to be engaged in the environment, but they are at risk for all of the things that any other child who's in the hospital are at risk of. So risk of plagiocephaly or torticollis, which is a tight neck, any contractures, and of course deconditioning from not being able to move. However, sometimes their technology actually allows them to now have the energy in order to do so. And the key for them, that's why I finished off with the seating position, is because early mobility is the key. We need to get these kids moving as soon as possible. Depending again on their age, what we use will be chosen based on that. But they are coping with this inactivity, and if they're not moved, if we don't engage them, if we don't play them, just like any of us, they can withdraw and they can lose skills, or they can become depressed or lethargic. And so developing routines, developing activity, through the day can help with promotion and prevention of loss of ADLs, and it can also help the parents and the family to be more active in their care. And it establishes routine, which makes the hospital environment a little bit closer to home life, which is always a positive thing. With the older children, you might see us working on not only the appropriate seating as we would with the younger kids, but also working on strength training and endurance training as they are trying to recover from their critical illness. And the goal would be to help them get back to whatever they were doing when it's time to go home, to get back to their normal routine. This might involve determining if they need gait aids like walkers, ADL assistance for them to get to reach an elevated toilet seat to make them a little bit more independent, bath seat, things like that. And then hopefully, if they are here for a while, hopefully we can actually progress things and help them get as independent as possible prior to when they leave us. The last thing we wanted to touch on is the issue of brain injury in the cardiac population. We know that there is an increased risk in this population. They are at risk of stroke. They are more at risk of cardiac events. They are at risk of seizures, which is usually related to one of those things. And it is important to know that physical recovery, so we see these kids up and moving, or they're starting to move their arms or their legs again, but this does not necessarily mean that everything is recovering just because their physical status is recovering. And just wanted to give you some notes about looking for changes in the quality of movement. So they often will have balance impairments, even though they look like they're ready to sit up and move around. And more importantly, looking for things that indicate a change in cognition. So looking for changes in memory, changes in personality, more irritability, whether they're impulsive, are they recognizing that their functional status has changed, and changes in their ability to focus or an attention on task. You might have a teenager who's had a cardiac arrest who is able to get themselves up and walk down the hallway, but will not remember that they did that yesterday with their parents. And so being sure you pay attention to that and ask those questions to help identify the right resources for that child. And the key players in all of this are really everyone. So I know we have a broad range of people listening in on this talk right now, but recognizing that all of us have a role to play, and you might have different support people wherever you're from, but this is really a team effort to help ensure that these children have optimal outcomes when they've spent a long time with us. Just to kind of summarize what we've been talking about, the important ways to help with the children's recovery, or outcomes from a developmental standpoint, is to set up the environment for success. So we talked about chairs, we talked about toys, we talked about screen time. Provide opportunities and experiences, whether it's positioning, whether it's being up in a chair, position them to allow movement when that's appropriate. Regulate the stimulation levels so that they're getting the right stimulation at the right time, when they need decrease stimulation for rest or increase stimulation to facilitate their engagement in the environment. Mobilize early and often to help prevent some of the sequelae that happen when we are in bed for a long time. And identify red flags that might indicate the need for physiotherapy or occupational therapy or child life referrals. So in summary, children with congenital heart disease do have altered neurodevelopmental pathways at times and are at increased risk of delay. We know that neurodevelopmentally supportive care can help with these delays across all age groups, and it is a very important aspect in the management of the critically ill infant, child, adolescent, regardless of their diagnosis. And the entire team, as I said, has a role to play in this. On the About Kids Health website, there is a resource, the Heart Learning Hub, and so we've just included that resource there in case you haven't heard about it. I'm sure you have, but there are some rehab documents on there that are very helpful as well. Thank you. I'll put my mask on so Kate can come over in case we have any questions. I think our volume's up, so if anybody has any question, I don't know if we're also watching the chat box, but
No chat.
no chat. Okay.
Not a question, but just a comment. That's a great presentation and good information that we apply to all our patients actually at CHEO, that not just the cardiac patients, but any patients that are in there for prolonged periods. So thank you so much.
Absolutely, yeah. So it wasn't a question. Just because I think that not everyone might hear it. It was a comment about how important this is to actually apply to not only the cardiac population, but really any of our children who are hospitalized for a prolonged period of time or who are ill for a period of time. And I think I would agree. These principles can be pretty universally applied to any child who's in the hospital. We know that admissions as short as 2 weeks can have an impact on developmental outcomes. So I think they don't have to have such a serious diagnosis, but they just need to have a hospitalization. And I know we know that will impact their outcomes. So
I like the discussion. It usually happens in the NICU about developmental care, not developmentally supportive care. There's a subtle difference there, but our colleagues in the NICU often talk about treating the baby as a human being that you are trying to support and treat, instead of them being this object that you are doing things to. So I'm trying to include their state and development in every single care. And some of you that might have done education on like trauma-informed care in the NICU or developmental care, you probably already know a lot of this stuff. But yeah.
And I guess the other thing I wanted to mention that I always do, even if my patient's sedated, is I always talk to them.
Yeah.
So give them that auditory kind of stimulation, and that is appropriate for their age as well.
Absolutely.
agreed.
So we have a comment here, which is saying, thank you for your presentation. Great holistic view.
We also muted.
Okay. All right. So thank you for your presentation. Great holistic view and of great importance for the acute and chronic stage of illness. Children should be children. Children should be allowed to be children as much as possible. Thank you, Pradeep.
We agree.